Okay, I'm going to start now. Good evening, everybody. Welcome, warmly welcome to the third EPOS webinar. We are talking this evening about clubfoot treatment in 2020. And I'm very, very happy and thankful for our speakers who agreed to share their experience. We welcome Cristina Alves from Portugal, Matthew Dobbs from Florida, and Mark Sinclair from Dubai. We would also like to thank Orthopediatrics for their support to make this webinar happen. Thank you so much for your support. The question is, where do we stand in clubfoot treatment now in our days in 2020? We put it up a little program for you to walk you through these topics. We will start with the genetic aspect. Matthew Dobbs is giving us an overview about the genetics of isolated and syndromic clubfoot. Then we are talking about treatment concepts, and finally we get an information about possible new evaluation tools, clinical assessment tools via Mark Sinclair. In the meanwhile, you have the possibility to ask some questions. You can use your question function over here and send me these questions, and then we try to answer as much as possible. Thank you for attending this webinar, and let's start with the first speaker. It's Matthew Dobbs from Florida. Welcome.
Well, hello everyone, and thanks, Stephanie. It's wonderful to be here, and this is a very exciting webinar, and I'm very pleased to be able to share with you some about the genetics of clubfoot, which is certainly near and dear to my heart. And I hope you'll get, from this that I really think, the genetics of clubfoot is the next frontier. This is going to allow us to eventually personalize clubfoot treatment, and understanding the etiology gives us a better understanding of helping our current treatment process even better. So this is a really exciting topic. And I'm going to cover sort of what we know about clubfoot genetics and etiology, what we don't know in particular, and then where we think we can go with this. How is it really going to affect and change treatment here in the future? So some of the things that we know here is that clubfoot is very common, right? It's 1 in 1,000 live births. The prevalence does vary by ethnicity a little bit. It's pretty consistent around the globe, but there's one area that's quite interesting and has a much increased prevalence, and this is in the Maori Island chain, so Hawaii and New Zealand, the Samoas, where it goes up, up to 7- to 8-fold higher. And from a genetic standpoint, there is a genetic basis for this increased prevalence there, which we'll talk about. The male to female ratio is approximately 3 to 1, though this is not a sex-linked trait, and we know this by multiple sort of pedigree analyses. And it's bilateral and approaching half of all cases. So here's more evidence for the genetic aspect. When you're able to take good family histories, and that's not easy to do, because family histories are a bit tricky to take in the clinic, and understanding who in the family truly had clubfoot or who had intone is sometimes hard to decipher. But when you take good family histories, it's approximately 35% will have a positive family history. And the pattern of inheritance is not Mendelian in nature. This is a multifactorial disorder, very heterogeneous, a lot of different etiologies that we are unfolding right now, but it is certainly not, one gene, one answer sort of problem. And there's increased risk. If you do have a positive family history, it again shows the genetics, you're much more likely to pass it on. One of the interesting things about this, which sort of showed that it's not sex-linked either, is that this is, you saw that it's more prevalent in males. So if a female has clubfoot, she's much more likely to pass it on to her children. And the reason for that is it takes more of a genetic hit for a female to be affected. And so then she has a higher genetic load, is more likely to pass it on to her future offspring. So when I first started thinking about, clubfoot etiology, this is long ago, I tried to be very simple in the thought process here, and I put clubfoot into the category of an isolated contracture, not a distal torticollis or hammer toes or idiopathic toe walking. But none of these do we know any sort of genetic factors for at the time. And so what is a broader sort of contracture type syndrome? Well, arthrogryposis is obvious, right? It causes multiple joint contractures. And certainly the distal arthrogryposis is much more similar to clubfoot because you can have isolated contractures of the hands and feet. The prevalence of the distal arthrogryposis, as you can see, is about 1 in 10,000, as well as with arthrogryposis multiplex congenita. But this was an area of focus, and there was a lot going on in the early 2000s in terms of trying to identify genes for arthrogryposis. So this is really where I spent some time and effort in the research frontier. And one of the hypotheses going along at the time was the hypothesis of fetal akinesia in the etiology of not just clubfoot, but human congenital contractures. And what is fetal akinesia? So it's lack of movement to the fetus during development. And there could be maternal factors for this, such as oligohydramnios, or fetal factors, which some of those are genetic in nature. And if you look at this sort of fetal akinesia sequence that can occur, you get the ultimate outcome of that, which is arthrogryposis multiplex congenita, where you have joint contractures, webbing, and all other features that go along with that. So, and again, in the early 2000s, genes were being identified for arthrogryposis multiplex. These are all muscle genes, right? So this is the gamma subunit of a fetally expressed muscle gene. And then in terms of the distal arthrogryposis, which again, more similar to clubfoot in terms of a more limited contracture, these are all muscle genes. So you can see here that I've sort of highlighted some of these, actin and troponin and the myosin head. All of these were identified in different subsets of distal arthrogryposis, which started to get a very broad classification scheme with many different genes involved. So I had families, as did many others at the time, that had patients with distal arthrogryposis that had clubfoot and vertical talus and hand contractures. I had a series of families, I'm showing one pedigree here, that had very mild hand contractures, but also had clubfoot and vertical talus in different family members. And you can see those are all the dark circles and squares elucidated here. And so we wanted to find genes for this family to see if they were already identified genes for arthrogryposis, or whether it was something different. And we ran across a different gene, a muscle gene, so it's myosin binding protein C. And this was causing arthrogryposis, and again, in multiple families that we had with these milder contractures. So again, clubfoot, vertical talus, and very mild finger contractures and nothing else. So this was interesting finding, and it sort of put us down a path as, could these muscle genes that are being unraveled be the cause of isolated clubfoot? And we started looking at the mechanism of how these genes worked and how they affected the protein folding. And we found out that the MYBPC1 worked differently than the other myosin genes in terms of how it affected the muscle contracture. And that's what this slide is showing, some of our lab work looking at that. So again, we started screening all of these genes in our large collected population, over 4,000 isolated clubfoot patients, and we really weren't finding very many mutations in our isolated kids at all. So it certainly wasn't the answer for isolated clubfoot in general. As we mentioned earlier, the clubfoot is so heterogeneous that there are certainly some of our isolated clubfoot cases that are due to muscle gene abnormalities, but it's not explaining what we think of as most isolated club feet. So we're kind of, back to the drawing board. And this is again showing you some of our distal arthrogryposis patients who actually had, this milder, hand finger contractures in club feet. So again, just that idea that there's definitely a population of isolated clubfoot patients that have muscle gene abnormalities. And as we get more sophisticated and can do better clinical exams, the isolated clubfoot category, I don't call it idiopathic anymore, as you probably noticed, is going to, diminish as we start to be able to sort of pierce these out with different clinical, features. I always have to put this in. He's many of our heroes. He was my mentor. I got to train with him for 9 years in Iowa City. And whenever I have clubfoot questions, I go back and think about him and see what he would say and ask. And I did this, when I was thinking about clubfoot etiology, and go back to some of his original work. And you guys, many of you have seen these slides from his collection, but he did a lot of sort of fetal dissections in clubfoot babies, stillborns. And this is a classic one that's shown with a stillborn with bilateral club feet, more severe on the left side than the right, and corresponding H&E slides. And this is the left foot, and the more severely involved foot. The medial side here, the tibia, the talus and the navicular. And what you can see here is the contracted, short, and thickened medial ligaments. And so Ponseti referred to this as retracting fibrosis in an attempt to sort of explain the etiology of this. He knew it wasn't a bone problem, but it was a soft tissue issue. But he went further than that, right? He looked at the entire limb. And he looked at the gastrocnemius muscles in the stillborn babies as well. And notice this is a unilateral clubfoot child, and you can see that the slide A is more atrophic and a short Achilles tendon. And what this tells us is that clubfoot is not a foot problem, right? It's not isolated to the foot at all. So the soft tissues around the foot are not the only issue here. It's an entire lower limb problem. He demonstrated that in the calf, and we have later demonstrated that even higher up in the thigh. So it's an entire lower leg problem. And this was a patient that I got to see with him in one of the classic Iowa long-term follow-up studies. And this was a young woman who he treated at birth with unilateral clubfoot. And you can guess which foot this is. The right side is the affected side, but what this is demonstrating that, again, it's not an isolated foot issue. It does affect the entire limb. I did an MRI study with one of my residents some years ago. We took a series of kids that had been through the Ponseti method of treatment, most being unilateral, but not all of them. And they had, successful casting, tenotomy, and bracing, no other surgical intervention than the tenotomy. And we did MRIs, where they were at least the age of 6, some a bit older than that. And what you can see here is a series of MRIs. The muscle is not normal, but everything is present and needs to be. So these kids function normally, but you can see there's more fat between the fascicles and the muscle fibers. This is not normal muscle, but again, it works and it functions. What you can see in this next slide, what you can see in the next slide is a series of patients from this same study, also treated with the Ponseti method alone, some bilateral that you can see, no further surgery, but these kids did have relapse issues. They experienced problems with treatment. And there's some pretty marked examples here, right, that show that you can have really marked involvement of the muscles in the leg. And you look at, this slide in particular here with G, there's almost no muscles in the lower leg at all. And you have very interesting situations here where you have on the right, isolated anterior lateral compartment involvement. And these can be translated into what we see clinically in some of our difficult patients. You can pick this up early on if you do careful exams. They can't dorsiflex their toes very strongly. They can't evert their foot very well. And there's a reason for that. They have isolated issues here with muscle development. And so we started to think, again, number one, this is a lower limb problem. So we need to look for other genes. This isn't just muscle issues. And so we started this journey of what I call gene discovery for clubfoot. And this started in Springfield, Missouri. So Missouri's in the middle of the United States, and here's Springfield in southern Missouri. For those of you that aren't familiar with this place, this is by no means the vacation capital of the world. This is in the middle of the country and not anything really going on there. And I took my children there for their spring break, and they'll never let me forget this to this day. And I took them there because we were following this family that I had to their family reunion. And this was the patient that I treated. This was a proband. And the dark circles and squares are other family members that were affected with clubfoot. So we went there and we drew blood from all the family members and isolated DNA. And this was back in the early 2000s. So we did linkage analysis to look for the gene involved. And we actually were able to find it. It's a gene called PIDX1. And we found this in other families after that, and quite a few. You can see that this was the proband. Obviously has much more than clubfoot, right? Has preaxial polydactyly and tibial hemimelia, but the other members had isolated clubfoot. And so PIDX1 is a gene involved in lower limb development. And so this is interesting. So the gene was known. It's not like it was a new gene that was discovered, but it had never been associated with any sort of human malformation. It has been studied in other animal species. And the interesting thing about PIDX1 is it is isolatedly expressed in the hind limb, developing hind limb. And the other interesting aspect of this is that asymmetry is a hallmark of PIDX1 and other animal species. And this can explain unilateral clubfoot. Because often the questions that I got early on with approaching genetic answers for clubfoot, people would ask me, well, if clubfoot is genetic, why can it occur unilaterally? But it can, and this is one of the genes that explains that. And the PIDX1 is differentially expressed in the developing hind limb, each hind limb at different stages of development. So you can have a normal, stage of development in one limb, and then the mutation occurs. and you can have abnormal development in the other limb. So it can explain a unilateral clubfoot phenomenon, which is quite interesting, but you can't explain it genetically. This is one of my favorite slides because this is showing the manatee, one of my favorite sea creatures, and I've moved to Florida where they're quite abundant. But if you look at, PIDX1, it can explain manatee development. So manatee used to be a land-dwelling mammal, and as evolution occurred and it went into the sea, it lost PIDX1 expression. So as it lost its limbs and it turns into the flippers, it lost PIDX1 expression, just showing the importance of PIDX1 in limb development and evolution. The PIDX1 that we normally found in early linkage analysis were haploinsufficiency states. So there was a one normal copy and one abnormal copy. And then we also found patients that we had with entire PIDX1 deletion and also caused isolated clubfoot. So PIDX1 was a true factor in clubfoot. The next sort of gene area that we found was on chromosome 17, and we found a microduplication in several families. I'm illustrated here, 4 of our initial families. And if you start to put this together, so TBX4 and PIDX1 are not unrelated. We put together sort of a story on this and other genes. So it's part of the limb development pathway. And so TBX4 is a downstream target of PIDX1. So they interact together in limb development, which is really quite interesting. And we also put together this slide that shows you some of the other genes that we have found in this limb development pathway that have clubfoot as a clinical feature. And this is not the end of the story. There's much more genes involved. But we started to put together things. And this is HawkC variants that we saw in clubfoot and vertical talus. And I can tell you that if you look through this historically, how we went about finding genes, vertical talus was an early gene find of ours. And we found it was a HawkC gene here, HawkC gene. And we thought, with vertical talus, we started having family members that had vertical talus in one patient, clubfoot in another, and some patients with vertical talus on one side and clubfoot on the other. So really thought we found the gene for vertical talus, and vertical talus is medially inherited, autosomal dominant, so it's sort of a one gene story. But we thought, boy, maybe we have the answer for clubfoot. So we screened a lot of our clubfoot patients, and yes, we have clubfoot patients that have HawkC, but it certainly was not an abundance. So it wasn't, again, the end of the clubfoot genetic story by any means. This was a very recent find of ours. It was just published this year, Schoch's duplications in clubfoot. And this explains in our large database, we've extended this further, about 2% now of clubfoot cases. So not insignificant in our isolated clubfoot kids. I'm going to give you a little bit more information on PIDX1, because this was, again, the first gene that we found, explains quite a bit, about 20–25% of familial clubfoot. And so we went on to develop an animal model. So this was the first animal model for clubfoot. It was a mouse. And we got, look at this, unilateral clubfoot, right? This is haploinsufficiency state. We got PIDX1 knockout mice and bred them with normal mice to get a haploinsufficient state. And about 7% of these had clubfoot, unilateral. So this is very interesting. We did everything to this mouse model except for cast it. And I can't find any volunteers to cast the mouse with me, but we did everything else to this mouse. We did micro CT and micro MRI. And again, trying to look at the entire limb, showing the limb development issues here. And we saw it. So you had complete reduction in leg volume. So this is including the bones, muscle volume, and vascular volume. So perineal artery hypoplasia, the muscle volume, you can see preferentially decreased laterally and anteriorly, which explains, this patient population had resistant club feet. So they can't dorsiflex very well and they can't evert very well, which puts them at higher risk for clubfoot relapse. And we see this in a lot, of our more difficult clubfoot patients, and those are ones that you might have that have PIDX1 abnormalities. We did some MRIs also in the human patients that we had with PIDX1. You'll see some interesting findings here. We've got thigh and we've got calf. And if you look down below, I color-coded the calf slide, and I want you to pay attention to the green. So then again, this is a PIDX1, high relapse risk. Look how small the lateral compartment is. So again, very weak everters. And they also have, for the most part, a 2-vessel leg rather than 3-vessel leg. And it's usually a lateral vessel that's deficient as well. So we kept asking now, I showed you some of the slides earlier, we had very interesting patients with isolated, anterior compartment aplasia or hypoplasia, as well as lateral compartment. And can you start to figure out, different genes associated with this? So is there truly like a genotype-phenotype correlation? And we have found that with some of the genes that we have. And if you look, if you sort of step forward into futuristic and some not so futuristic ideas of how is this going to affect therapy, because this is another question that the clinician, wants to know is you figure out the genes for clubfoot, how is that going to change treatment? Well, number one, I can tell you, some of it already has. And what we see clinically with lateral compartment and anterior compartment deficiencies, not aplasia, but hypoplasia, I and others have used, E-stem. It's a method to increase muscle volume if muscle already exists. Now, obviously, it doesn't work if you're aplastic. You can't create muscle through E-stem, but you can increase strength, and it's a modality that I use in selective patient populations. And a little bit futuristic here, can you start to think of gene therapies and potentially some pharmaceutical interventions? And I put myostatin here as an example. So myostatin, keeps our muscles in check in terms of growth. And if you knock down myostatin, you can increase muscle growth. And this is a naturally myostatin deficient animal. And if you look at the mice over here, this is the same age, same sex mouse. And one is myostatin deficient, and it's the big one. And so this is not a fat mouse, this is mighty mouse. So this is a very muscular mouse. And so, again, can you selectively think of knocking down myostatin in a developing limb bud? So that could be even done in utero or even after a birth. Can you selectively deliver that to a developing limb and increase muscle volume? And that sort of thing is, things we need to think about. If you jump back to the sarcomere gene mutations, because I told you some isolated clubfoot are due to muscle mutations. There are some interesting new developments in the muscle world in terms of pharmaceutical interventions. And it's being used right now and trialed in Duchenne's patients trying to increase muscle growth with some success. So this, these sort of interventions may be possible as well in terms of being able to offer clubfoot patients. So again, something to think about. So we're looking at different pharmaceutical options as well as different sort of gene screens. And what we've gone to now is a zebrafish model. Now I can't, we didn't use zebrafish for our clubfoot model for obvious reasons, because the fish don't have feet. They have fins, and the mice have feet. But the zebrafish is a wonderful animal model for many other things, because it's the embryonic development, they're translucent. You can see the entire skeletal development. And they breed like fish. So you get lots and lots of different embryos to be able to do things with. And this is an interesting thing that we did. It's called a photomotor response in developing zebrafish embryos. And if you shine a light on a normal embryo in a zebrafish, the response to that is the embryo starts to move around, and you're going to see this. And so on the first screen that I show you here is normal developing zebrafish embryos, and on the right is we've developed an arthrogrypotic zebrafish model. So it's not clubfoot, but it's arthrogrypotic. It's a contracted model. So if you do the photomotor response, it doesn't respond very well. So this is the normal embryos, shine a light on them, and then all of a sudden they start to move a whole lot, right? And so that's a normal response. And if you do the same thing over here on the right, this again is the more contracted zebrafish, and they're going to get some movement in some of them, but not a lot, right? It's interesting. So that's our arthrogrypotic model that we're doing, again, a lot of pharmaceutical interventions on. I'm going to sort of end with talking to you about a large clinical trial that I completed, and this is, I guess it dates now to 10 years ago when we started this. And it's called the FAB24 Clubfoot Bracing Trial. And it's much more than bracing. And so we randomized, this is a 9-centered study, and we randomized isolated clubfoot kids into 2 versus 4 years of bracing after treatment with the Ponseti method. And more importantly, during this, we also we measured a whole bunch of factors. We did, their ability to move their foot, evert, dorsiflex their toes. We did calf circumference, we did foot length versus foot circumference ratios. And we tried to put together a clinical picture at the end of the day. If you could do these exams, this clinical exam on a child with clubfoot at every stage of their casting process, can you more accurately predict which child is going to relapse and who's not? And this is really exciting. This is actually, we're going to be publishing this next year. So the data is being compiled right now because we went through all the 4 years of treatment for the group that had 4 years of bracing and then followed them for an additional 4 years. And so we've got, but really had true relapse rates in this patient group. And what I can tell you is that, you are going to be able to have, a good clinical exam you can do that will help you categorize kids into risk stages. It doesn't tell you exactly how long kids need to be in braces, but it is going to tell you who's at higher risk and who's not, and potentially who needs early tendon transfers, who's going to fail bracing, who can potentially stop bracing earlier than 4 years. So it's exciting. I think, this again is the future, and you can apply all of this. The clinical features that we're doing are based on the genetics that we have found in terms of muscle compartment loss and hypoplasia. So genetics, is and will change the future of clubfoot treatment. It's going to change the classification of clubfoot, where it's going to be prognostic rather than purely descriptive. And it's going to usher us into a new age of modern medicine. And we do this for high blood pressure. You're going to take your blood pressure medications based on your genetic profile. What do you respond to and what do you not? And it's the same thing. There's no reason we can't personalize clubfoot management, because clubfoot is very heterogeneous, and one treatment strategy overall is not going to be successful in all patients. So it's important to sort of think of this out of the box a little bit. And this is the reason I put these, very extensive examples here, but this just shows you that all club feet are not created equal, right? And so you really do have to think about different potential strategies. And this is the ultimate, the goal is to try to identify, at this, prenatal stage when the couples, come into your office, and you can sort of then, if you had a genetic profile sort of done, you could personalize treatment strategy for them and tell them what to anticipate and expect. And with that, I'm going to stop and I think turn it over to you, Stephanie, if there's questions.
Thank you so much, Matt, for your great presentation. There are no incoming questions so far, so I like to ask the faculty to put on their cameras and to unmute. And I would like to start with a question to you. I'm wondering, how did your findings affect your daily practice? You're talking about electrical stimulation, you're talking about physiotherapy. Are there any programs you made out of your findings?
Yeah, thanks for your question, Stephanie. And I certainly have, I can't really separate my, sort of research arm, versus my clinical arm. Just what I studied and do, I directly apply to my practice. And so, yes, I have, physiotherapy involved in high-risk children. So it's not my standard for all clubfoot kids, but those that I've identified at higher risk will get physio involved early. E-stim also involved early, and those at higher risk that as I mentioned, that meet the criteria for that. And then bracing decisions, I am personalizing that more. And again, the data will be shared with everyone very soon in a publication, but I am personalizing treatment for those at high and low risk for that. So it is changing my clinical practice and how I do things.
Do you recommend stretching exercises to all your kids, no matter?
I do. So I do. I don't recommend formal physical therapy or physiotherapy for all of my patients, but I do engage parents in stretching. And I think it serves a couple of roles. It's carefully reviewed with them at each visit. Number one, there's handouts on it as well, but it engages them. And that's one of the most important things. If they're engaged in the treatment process in general, they're more likely to be compliant. And so this, they're not completely passive in this process anymore. And so they've got things to do. And I think that really makes a difference. And I also think it really does. When it's done properly, it helps, increase ankle dorsiflexion long term.
Mark, do you have any question?
Thank you.
Not so far. No. Cristina, any questions?
Yeah, I have a comment. I think more and more on what Matt said about idiopathic club feet. I do a neuromuscular clinic with the neurologists, so I became more aware of subtle changes that some children have and are not apparent when they are babies, and particularly when a child who completed the bracing protocol with a very compliant family, if this child has a relapse at age 5 or 6, I asked neurology to have a look on them. And I think we have more children with non-idiopathic club feet than we think. So I really got that message from your talk.
Thank you.
Mm-hmm. Matt, I have another question regarding complex and atypical clubfoot. I think Cristina is going to address this as well a little bit later on, but I understood from you that you have a very good definition how you see to this. Could you share this with us? I think it would be helpful for everybody.
Yeah, I'm happy to share it, and others may think about this quite differently. So I don't want to, put words in other people's mouths, but I do think there's a little bit of a semantics, issue that goes on with those two terms. I think the commonality is that the end treatment pathway in terms of casting modification is the same for atypical and complex. You do the modified casting technique that Punch City shared with us. But your atypical feet are your neurogenic feet. This is the way I look at them. So these are neuromuscle feet. These are the ones that can't dorsiflex, that can't invert very well. There's a neuromuscle problem going on. Complex, for the most part, those are feet that have normal muscle function. They can dorsiflex and evert, but they're hard. They're hard feet, and people run into trouble with these in terms of casting. But they're not atypical. But when you run into trouble, you modify the casting technique. But the fun thing to me about the complex feet is once you do that and you correct them, they actually do very well. They do well long term. Their feet look more and more normal over time. They function great. The relapse rate is not higher, and that's not the same with atypical. You get them corrected. This is going to be a constant struggle because they can't maintain the correction. So these are kids that need more casting, need more surgery sometimes down the road. So they're two very different entities in my mind.
Mm-hmm. Are you going to share this in a written way with us someday?
Yes, I am. Yeah.
Very good. Mm-hmm. There are no further questions, so I think we are going to move on with Cristina Alves. We are very happy that you're here, Cristina. Cristina is also an expert in clubfoot treatment back to many, many years working in Coimbra in Portugal. And she's talking about current treatment concepts and gives us a literature update in 2020. Where do we stand? Will be very exciting.
So I'm very happy to be here and part of this panel. And I will share some of my experience and some of my doubts too. So we learned from Matt that clubfoot is a congenital foot deformity, and there's a lot of genetics into it. We can see that usually there is cavis, adductus, varus, and equinus of the foot. If we look, and I've looked at this yesterday on PubMed, you'll see that there are thousands of results when you search for clubfoot. And when you search for clubfoot treatment, you have around 3,000 results. And Ponseti, you also have a lot of results when you go on PubMed. So what are the goals of clubfoot treatment in 2020? And I still think pretty much the same goals that I've learned from Dr. Ponseti. You want a foot that looks normal and functions in a normal way. And functioning in a normal way can be different if you live in the city, in the country area, if you like sports, or if you don't like sports. So there's a lot of heterogeneity in this, but certainly you don't want the child to wear modified shoes or inserts or have pain. The last Cochrane review I got into identified 21 trials with 905 participants. And I must say that I think most of the evidence that we have on clubfoot treatment was mainly coming from level 4, level 3, and level 5 studies, not from level 1, though there are a lot of few level 1 studies like randomized clinical trials and randomized clinical trials that show that Ponseti technique is superior to other techniques of clubfoot treatment, and maybe you can be as effective when using fiberglass and plaster of Paris doing Ponseti. I'm not so sure about this unless you're very experienced, so I look at this with a little bit of careful. There's also a lack of evidence for the use of botulinum toxin during the Ponseti method, namely to replace tenotomy. I think most of the literature shows us that Ponseti treatment is efficient, simple, fast, economical, effective, and has long-lasting results. And it's mainly a technique of clubfoot correction by gentle manipulation, followed by the application of thin and well-molded casts that go up to the groin with the knee bent at 90 degrees. It's a specific method of manipulation, casting, preventing relapses and treating relapses, and I would say it's a whole philosophy on how to treat the foot. Ideally, treatment should be started within the first month of age. There is some literature showing that perhaps if you start within the first year of age, the results are not so different if you start in the first 6 months or after the 6 months. But we all, in normal circumstances, would like to start treatment when the mother is fit and well and the baby has a foot that is big enough. In premature babies, you may want to delay treatment, and there's some literature talking about the size of the foot. Where are we in the COVID-19 area? And I've contacted some people to know what they were doing with the clubfoot treatment when all the pandemic era exploded. And there were different approaches. So I would say each one of us should do what's possible in its own institution and safe for the patients. We actually maintained clubfoot casting. The only changes we did is that everybody was using the mask except for the baby, and there was a defined circuit for patients in the outpatient clinic, and only one parent was allowed to come with the baby. Certainly, this is a little bit difficult for a technique where teamwork and family are very important part of the work, and of course we all have to do nice thin well-molded casts, but it's important to have a relaxed child and involved family. And there's recent evidence showing that parents and family distress can be very important at the beginning of the treatment, and you should reassure them about good results of the treatment. The principles of Ponseti treatment are simple, but there's a lot of detail, and you have to be really attentive to detail and know well the pathologic anatomy of the clubfoot. I personally like to use the Pirani classification when beginning treatment and before each cast, because it gives me an idea of the evolution of the treatment and how the foot is reacting to casting. Other people prefer to use the DiMeglio classification. Both have been widely used in research and try to classify how stiff is the foot. What the literature says globally is that both the DiMeglio and Pirani scores are widely used. However, their prognostic value in predicting the number of casts and treatment results still remains questionable. I think it's really important for the ones who are treating clubfoot to be aware of the pathologic anatomy of the foot, and you know that there is equinus due to the severe tibial-talar flexion. There is plantar flexion of the calcaneus, there is cavus, there is adduction and the medial displacement of the navicular bone. The navicular is wedge-shaped, and the calcaneus is adducted and inverted. Ponseti manipulation technique is very well explained in Ponseti's papers and has not changed since he first described it. So you have to identify the head of the talus, which is usually in front of the lateral malleolus, and then you have to put your thumb or index finger, depending on how you do the maneuver, underneath the first metatarsal to undo the cavus and bring the foot into abduction. And it's very important to keep bringing the foot into abduction and not pronate the foot, because if you pronate the foot, you will increase the cavus. It's very important to have a well-molded cast. We usually do the casting 2 times, first below the knee, then above the knee. I use the 2 hands and the 1 hand manipulation technique. Usually it's important to have a good assistant, and you have to, it's good if you look at your cast when the child come in for the change cast, because a sleeping cast has to be recognized and is a major factor in the development of a complex or a typical clubfoot. It's also very important to go way up to the groin with the cast and then trim the cast so that the child can do extension of the toes. The literature has shown that an accelerated protocol where you change the cast as every 5 days can be as effective as a protocol where you change the cast every 7 days. You can even change the cast every 3 days, although it's not recommended. But if you have a family from another city far away, you may consider shortening the treatment time and changing the cast every 5 days. Pirani has beautifully shown us that with Ponseti treatment, there is a correction of the abnormal tarsal relationships, and that most of the corrections occur in the cartilage, not in the ossific nuclei. And treatment produces nearly normal enlogin shapes and positions of the bone after a completion of the treatment that are very comparable to healthy children. So the method works because of the biomechanics of manipulation, the viscoelasticity of the ligaments, the talus, and then bracing maintains correction. Ponseti was very keen on the concept that the whole foot moves underneath the talus, and there's explained very well by Furbuff and Husen the concept of the calcaneo pedis block. It's very important to use the talus as a fulcrum so that the a calcaneo pedis block moves underneath it. Otherwise, you will end up with the posterior displacement of the fibula, which is iatrogenic deformity. The last deformity to correct is equinus. Passetti recommended to do tenotomy after the foot has been abducted at least 60 degrees and when there is less than 15 to 20 degrees of dorsiflexion. Some authors and some groups use Pirani score to monitor the treatment progress and to help finding the right time for percutaneous Achilles tenotomy, but basically you should only do it when the heel is in valgus and you have at least 60 degrees of abduction of the foot. Tenotomy is done by most authors in about 80 to 90% of the patients. We usually do it in our institution under local anesthesia. It's an office procedure. We do it, usually we don't even use lidocaine. We use amla cream for 40 minutes, and then we palpate the tendon about 1 centimeter above the posterior crease and do the cut from medial to lateral. I like to use an 11 blade. You can use an ophthalmic blade as you wish. But several groups have shown that the tenotomy can be safely done under different anesthesia protocols, with the choice being mostly dependent on the setting and experience of the surgeon. There are possible complications. Matthew Dobbs was one describing it, and they probably happen in less than 2% of cases, and namely there can be bleeding due to injury to the peroneal vessels, or even a major injury of the posterior tibial neurovascular bundle, or a pseudoaneurysm has also been described. We have to be aware, for the ones who prefer to do general anesthesia, families may ask you about the effects of general anesthesia under the age of 3, and there are some worries about it. So that's something you may want to discuss with your patients. Multiple studies have demonstration that the tendon is healed after 3 weeks of cast, and the Morquendi study from 2006 has shown that probably hyperabduction, 60 to 70 degrees of abduction of the foot in the last cast, is important in preventing relapses. It's very important to perform the tenotomy when you have to do it. If you don't do it, you end up with a rocker bottom foot. And if you're in doubt, if I'm in doubt, I do it. But if you're more conservative than I am, maybe you may want to perform a lateral maximum dorsiflexion radiograph of the foot and look at the tibial calcaneal angle and decide if you want to do or not the tenotomy as Chris Radler describes it. So the last cast is not the end of the treatment. You should have upper abduction 60 to 70 degrees and 15 degrees of dorsiflexion on the last cast. But during this time, you should have been explaining the family that they will have to do most of the work. And most of the work will go on for, we used to recommend bracing for 4, 5, and now some people even recommend it to 6 years. I usually recommend it to 5 years. And for the first 3 months, we recommended 23 hours a day. And afterwards, there's a lot of controversy. We usually do a weaning protocol, doing 18 hours the next 3 months, and then 16 hours the next 3 months. And then after the year of age, 12 to 14 hours. I see commonly some children are well corrected and come for a second opinion to a possible mild relapse. And sometimes the problem is that the shoes are not in the right rotation. So sometimes it's the person in orthotics applying the shoes and not doing it well. So I think you should always look at the brace of the child when it's applied. Or boots are not comfortable enough, and they don't need to be Mitchell to be comfortable. They can be any brand. They can be more or less comfortable, but we have to work on it. Or insufficient bracing time, and the common error is the bar is short, so the distance between the heels should be equal to the distance between shoulders. So there are a lot of strategies to improve bracing. We actually know that parental non-adherence with bracing is a problem that can affect about 1/3 to 2/3 of the children and results in much higher odds of recurrence of the clubfoot deformity. So I really need that we think that we all, doctors and families, need to be committed to bracing and define your follow-ups protocol according to the family we have. I don't think we should do every 6 months, every 4 months. So some families will need to be seen every 4 months, and other families maybe need to be seen every 3 months or less. So you have to define this according to family resources and your resources, or you even may have a nursing clinic who calls up the family and sees how they are doing. So we are very good at correcting clubfoot with an initial correction rate of 90% or more. I would say 100% in idiopathic clubfoot. We have not operated one in ages, but recurrence rates can be as big as 50%. And Matt Dobbs has shown that bracing tolerance and parent education level are associated with recurrence. In spite of that, and there are lots of possible causes for relapse, maybe the soft tissues in clubfoot, genetic and neuromuscular factors, as we've seen, different braces and variable bracing protocols. But certainly we have to recognize it. It's very rare to have a relapse in a child who is using the brace well, but if the brace is not fitted or the foot has not been well corrected, if you see a red heel, or if the parents are complaining that the foot slips off the shoe, there's some loss of dorsiflexion, then you may want to recast and rebrace the child and see where you can improve. After the walking age, normally you will see supination and they are walking on the lateral border of the foot and some heel varus. At this time, we usually offer us either casting and bracing if they are having problems with bracing, or you may consider a tibialis anterior transfer to the third cuneiform after correcting the foot with casting. So it's very important to correct the foot with casting before doing the transfer, and heel valgus must be obtained. There are a lot of techniques to do the transfer. I still use the old technique described by Dr. Ponsetti with the tunnel through the third cuneiform and the button in the plantar aspect of the foot. I have used anchors in a few patients, but I didn't have such good experience. I find it difficult to know how much tension should I have. And after the transfer, I usually use cast for 6 weeks. So you have 2 options if you have a recurrent or relapsing clubfoot. And depending on the age of the child and the family physician preferences, you will recast and correct the deformity, return to bracing, or you will correct the deformity and perform a tibialis anterior transfer, usually associated with tendon Achilles lengthening, or sometimes you will correct the deformity and observe. The results of tibialis anterior tendon transfer are described as good, though there are still relapses after tibialis anterior transfer. It can be up to 15–16%, which in my mind must be related to some neuromuscular changes. I think we should also pay attention to the possibility of casting these children and not doing a tibialis anterior transfer. There's a reported 74% rate of success at Sick Kids Hospital. This casting was done by Barb Harvey, who is a physiotherapist, very skilled in Ponseti casting. And I think that the results are very, very appealing. And so there are, however, we've talked about idiopathic clubfoot, but there are challenges in other types of clubfoot that can be challenging. So neuromuscular clubfoot can also be treated with using the Ponseti protocol with serial casting, tendon Achilles tenotomy. The number of relapses will be, or recurrences will be up to 50%. There are groups like recently I've seen just the abstract of the paper, could not access to the paper, published by Arugis, who report an 87% rate in the correction of myelommeningocele clubfoot. Stephanie Bohm has also described treatment of arthrogrypotic clubfoot in the literature, but myelommeningocele, the group of Cristina Garnett, has also described nice results. But again, the rate of recurrence is higher and can go up to 70%. So we have perhaps to be more persistent with these feet, and it's very important to be, particularly in myelommeningocele, that we don't see much more in our country. But I remember a case when there was a sudden correction, and in fact there was a fracture of the tibia, so they can be very osteopenic, and they can, as they have no sensation or less sensation, they are more prone to have blisters without complaining. So attention to detail is very important, but nice results can be achieved around the world. Arthrogryposis is another difficult pathology, but both Stephanie Bohm and Jose Morpende and Matthew Dobbs have taught us that it's possible to treat these feet with Ponseti method, though they can relapse more. I particularly like the approach of Harold Van Bos, who seems to be very conservative and trying to do a Lockhart treatment to arthrogrypotic clubfoot, not being very aggressive in doing much surgery and trying to have them in a plantigrade foot and using orthotics as needed. So you may need to use AFOs during the day and do a customized shoes for these children. And finally, we go to a typical clubfoot and trying to find the definition. Probably I should have talked with Matthew Dobbs before, but I find the definition from the article from Dr. Ponseti, and he defined this clubfoot having rigid equinus, severe plantar flexion of all metatarsals, a deep crease above the heel, a transverse crease in the sole of the foot, and a short hyperextended first foot. And these will be very rare in your practice if you're doing well the Ponseti method. They are usually short, fat feet with rigid equinus. The first toe is hyperextended. There is a cavus, a deep crease in the plantar aspect of the foot and the posterior aspect of the foot. And it's kind of difficult to palpate the talar head, which usually more up, and it's nice to look at the lateral malleolus and then find the talar head just in front of it. And sometimes you can have a procurvatum deformity of the tibia with tibia bowing, and for the rest, the child seems to be neurologically normal. So you have to exclude arthrogryposis, myelomeningocele, or myopathy or some kind of neuromuscular disease. So usually the foot is also much smaller. If you have an unilateral typical clubfoot, the foot is much smaller than the contralateral clubfoot. We don't really need imaging, but we have imaging from Dr. Ponseti and Mark Sinclair showing us the severe plantar flexion of all metatarsals. So is this primary atypical? Are these feet born like this, or do we cause the deformity, this exaggerated deformity, due to our manipulation technique? And this is a controversy. I think some feet are born atypical, but certainly most of the atypical club feet, defined as so that we see, are probably the result of a manipulation which has not been as good as we would want. Usually they will have they can have there's a lot of theories for their etiology, like improper casting, contracted plantar intrinsic muscles, and it's important to look at the peroneal nerve functioning and see if they have a drop toe sign. And it's usually the forefoot deduction can be easily corrected with casts, but then continuous attempts of abduction put the metatarsals into additional flexion, and the hindfoot varus cannot be corrected. And maybe there is some genetics into this, and then increased recurrence risk, which some authors have not shown. And usually it's difficult to manipulate. They are very sensitive, and but once you get it and you do the right manipulation, you can achieve nice results. So how do you do it? If the child is too sensitive, you may consider waiting for a time, giving them a break, and then restarting treatment. But once you recognize it, you should use the modified maneuver, where you identify the head of the talus and put your indicator fingers on the head of the talus and use your thumbs to dorsiflex the anterior aspect of the foot, and bring the foot into about 30-40 degrees of abduction. And then once you are there, you can think about doing the tenotomy. I usually use some splints to in the knee and front of the knee, so that I don't have to use a lot of casting. And Dr. Ponseti and some authors used to recommend casting in about 100 to 110 degrees of flexion, but I personally am not good at doing that, so I try to keep the 90 degrees and do a very well molded cast. It's important to do the tenotomy about 1.5 centimeters above the posterior skin crease, because they have very rigid equines, and we don't want to cut the calcaneal tuberosity. We want to cut tendon, not cartilage. And 5 degrees of dorsiflexion just past neutral and less than 40 degrees of abduction is enough. And you may want to change the cast after 1 week, and actually the results will improve with time. And for the bracing, you want to put the brace as you put the last cast, with 30 to 40 degrees of external rotation. There is a higher complication rate in this feet. The cast will slip. You may have foot edema, bruising. You may have a midfoot hyperabduction, and the relapse rate is higher. So you have to warn the parents, and you may want to tell them that they may need more casts, and you may want to have a follow-up more tight with these children, but they will improve with time. All the plantar creases will improve with time, and they come in different aspects. These complex club feet, you may need then to treat them later on with the tibialis anterior transfer and further casting. Last but not the least, we'll talk about a little bit about treatment in older children. So this, when I met Dr. Ponsetti, he told me that his method after 1 year of age probably would not work. And this is something that we've learned that works and has been used worldwide. It's not easy to manipulate children and cast them after walking age, but it's possible. We never use general anesthesia or sedation. We use every technique like toys, put the child on the mom's lap, and we are usually able to treat them with not more casts than we usually do for younger children. In children who are even older, and were called neglected club feet, more common in some countries of low-income countries, the Brazilian group and other groups have described amazing results with Ponsetti treatment, just with casting and tenotomy or tendon Achilles lengthening. Bracing is certainly a challenge, and it's questionable if some of these children really need bracing or will need brace. Certainly not at age 16, they will not use a brace, but they can be corrected, and there are some anecdotal cases that I've seen all over the world shown by people who are very skilled at doing Ponsetti method. And there are also reports in the literature showing us that children after walking age and even teenager children can be well corrected in 80 to 90% of cases with the Ponsetti method, although it's difficult to evaluate outcome and define what is a good outcome. You certainly have to understand your local resources, and in some children consider tibialis anterior transfer right away if they are older than 3, and if you have the resources to do that, and if you can use fiberglass as an outer layer so that they can walk. A last limit would be, is it possible to treat a child with Ponsetti method, a child that has been operated? And yes, it is. Again, the results are not so good as in idiopathic club feet, but some groups have shown nice results, probably with more casts, but you can certainly obtain a plantigrade foot, although the relapse rate is higher. External fixator is an option described by some authors. I would say that this is reserved for the very difficult cases, although John Erzenberg and other Ponsetti people have been describing the use of external fixator to use recurrent club feet. Last but not least, long-term results that we know of Ponsetti clubfoot treatment are quite good, and the original series from IO had a few patients but showed us long-term excellent and good outcomes. Matthew Dobbs showed us that certainly it's much better to do Ponsetti method than to treat surgically a foot, as your quality of life, if you have an operation for a clubfoot, is pretty much similar to someone who has chronic heart failure when you're using SF36. Also, other groups, mainly the Texas Scottish Rite, has shown us that clubfoot treatment yields good results when considering ankle motion and gait, although some changes were apparent in the clubfoot when compared to normal foot, namely in terms of power and foot pressures, but nonetheless children were quite functional in their teenager years. Last but not the least, I think we have learned some other things, and I think it's interesting that it has been shown us that gross motor skills in children with idiopathic clubfoot may not be the same as their normal peers. So we should be looking at this when we see patients in clinic. So we still have a lot to find out, and certainly relapses are one of my areas of interest, and I think we are all willing to know what the fabulous trial from Matthew Dobbs and others will show us. As a take-home message, I would say 20 years ago, we are still doing a teamwork. Every detail is important, and 100% success is possible in initial correction of idiopathic clubfoot when using Ponseti method, but we may have to use other strategies like tibialis anterior transfer for some children, or further casting, and we do have to modify strategies for complex and difficult clubfoot, and certainly there's a learning curve, but there is no lost feet. And I would like to thank you all and invite you to hopefully what will be the 39 EPOS meeting in Porto, April next year. Thank you.
Thank you so much, Cristina, for sharing your experience with us. Fantastic listening to you. And they're actually coming in a couple of questions, which you may kindly answer. First of all, somebody's asking, Cristina, do you change cast once a week also for older children? Talking
Yes.
about children older than 10 years.
Yes.
Once.
In my current experience, it's very rare to have a child over than 10 years of age. But for older children, I change every week, mainly because I don't want them to be in the cast for a long time and osteopenic. At the beginning of my experience, I used to change every 15 days. I don't have evidence to say this, but my personal experience, I don't think it matters. I think every week is fine. They don't need to be in the cast for 15 days, and then they will be for a long time in a cast. So I change every week, yes.
Matt and Mark, what are you doing? You change weekly, also in older kids? You change cast weekly?
I do weekly. I base it on their travel availability. So some of the kids who are coming to see me are traveling from far away, and sometimes 2 weeks is better for them, and so I do some, 2 weeks, some 1 week, and some combination. I really do whatever's convenient, but I agree with Cristina. I don't see a clinical difference or need to be on beyond a week.
Good. There's another question. I think this addresses you, Matt. People are wondering, how often do you perform an MRI? Only in relapsed cases, only in the atypical clubfoot, or also routinely, or do you perform MRI?
So yeah, to answer that, and there's another question that came in about the ordering genetic tests. I can probably address those both together. So I do not routinely order genetic tests or MRIs. And so that was, the gene finding was a research, sort of exercise to help figure out what's going on. I mean, it's not something I recommend it clinically be done, because it's not going to, directly affect your care more than your clinical exam would. And it's the same with the MRI. It was sort of done to verify what's missing and correlate that with the physical exam. But your physical exam can pick that up. So those are the features that we will be publishing, in terms of that exam, exactly what we do, what we measure. But it takes the place. You don't need to get an MRI to verify that. You will see that on your exam, and then it correlates. So it was a research thing to figure things out, but you don't need it clinically.
There's another question to Cristina. How is your brace protocol for older children? I think you mentioned that, but could you repeat it kindly?
So for children up to the age of 5, I will, for the first, when I correct a child, I will use 18 hours a day. And then, so they stay 6 hours off for the first month. So just that their brace gets in their mind, and then just use at night until 5 years of age. Usually after 6, I would not do bracing. I would offer the family just casting and tibialis anterior transfer as part of the treatment. So let's say I will do the casting and then the foot is corrected, and we can add tibialis anterior transfer as internal bracing to the foot, so that we know that we'll hopefully not relapse. So again, there's no evidence for this, but it's what I think it works. But I discuss it with families. So if they just want to have bracing, casting and bracing, and if the child is 5 or 6 or 7, I will do that. But I don't know how easy. I think I only got it once with a very special family that at 3 years of age, they did not want general anesthetic for the tenotomy. So we had to give some mixture to kind of put the child to sleep, but not anesthetize. But otherwise, I don't think that most of the families I see will want bracing after the age of 5 when the child goes to school.
More questions coming in over here. It's actually a question to Matt. Have you noticed?
Stephanie, Mark had a comment on that.
Yes, sorry,
I just
Mark.
had a question for Cristina. Sorry, I just the first one. Now that I'm back online again, for Cristina about relapses, because I find that when the older the child is, the more you're tempted to put on a short leg cast for relapses. My personal experience is that they don't work as well. I've heard from many that they work just as well. In my hands, they don't. The amount of correction I get if I go above the knee is just so much better. And although it is a problem to parents with, say, 3, 4, 5-year-olds, I really see the benefit in long leg casts, even in the older child. Would the panel agree with that?
Yeah, I would say I would make one exception, is the child with in which the parents are not very keen. So I will do the first cast below knee, so that they get used to the idea, and then after 1 week I will do the second cast above the knee. So it's just to await people. But I think you're right. I cannot get the same amount of correction.
I do it actually the other way around. I start with a long leg cast because I feel that I get my subtalar or the abduction, and once I work on equinus rather than subtalar derotation or whatever you want to call it, I take a short leg cast because I feel that will improve dorsiflexion.
Yeah.
I agree with you. I agree with you, Mark. I also, long leg casts are much more effective for me. What I do in the older child is I do not bend them 90 degrees. I make it a long leg walking cast, so they can get around a little bit easier for them. But I completely agree with you. Short leg is not as effective in my hands.
Total agreement. Very good. Matt, the audience is wondering, have you noticed a higher incidence of early termination of the pregnancy in terms of genetic abnormalities? Higher risk, more terminations?
No, I haven't seen that. That's always obviously a concern if you start to put this out as a clinical test. The genes that we have found for clubfoot, I mean, these are not sort of what we call them in the US anyway. It's not a CLIA certified test. So this is not, it's not being used clinically. This is, what we have found, our panel of genes is on a research basis, so it's not being used in that light. So we have not seen that.
Might this be something for the future? You see this in the future?
So I don't think so for clubfoot, because I think, what you can get down to is, the genetics in our hands is sort of to guide, different treatment strategies. It's not, it's not, there to, sort of guide anything else. So I don't, think ever as a prenatal test, clubfoot genetic testing is really the thing to do.
This is the next question is a hot potato. People are wondering what is the upper age limit to perform tenotomy in the clinic? What do you say?
The oldest I've performed was 3 years of age, but usually my cutoff is 1 year of age. So if they are younger than 1 year of age, I do it in clinic, unless I would do the only exception, would say that the only exception would be a difficult, atypical, like these chubby feet that you older than 6 months of age and you cannot really feel the tendon, and so this would be the exception. But I only remember having done one and he was almost a year of age. So year of age would be my limit to do it in clinic, but I've done 3 years of age, and so that's it. Then the other hot potato would be complete tenotomy or step cut. So I would, that's something people ask a lot. So again, I don't think that there is evidence to tell us what's best, though I've seen Cesar Fonteca from Barcelona did a study and he showed that the scars that you do from step cuts cause more fibrosis to the tendon, and on the long run, the tendon can be less stretchable. So, but I usually will do complete tenotomy until the age of 5, and after that I will do the Hoke type lengthening. But Brazilians do much older, to much older children. So,
Mark, tenotomy in the clinic, up to which
Absolutely.
age?
Yes. Up to the age of, I think 1 is a good time. I think it depends very much on culture and also on the parents, to be honest. We have some parents that would not want their child to have a tenotomy in the clinic, and to start with, say, oral midazolam or things like that, it's probably better to just take him to the OR and just do the tenotomy.
Yeah, that's totally true. You might agree, Matt,
to the second
with
hot
that?
potato, I would do a tenotomy, a full tenotomy.
Yeah. Any comments on that, Matt?
No, I'm in agreement with everyone there too. It's a year is what I use as a general rule of thumb for tenotomy in the clinic. The exceptions for me are the oddball ones, like the myelo patients that are insensate. I'll do that much older in the office. And then if you have really high risk anesthesia kids, some of the complicated syndromes, then I will do those older in the office just to avoid anesthesia risk. But other than that, normal isolated club feet a year is where I like to be at as well.
Well, that's total consensus over here. It's rare. Very nice. Cristina, there's another question for you. Nighttime bracing difficulties. How do you encourage parents to use the brace for nighttime?
Well, I think it's important so that we understand that some families will tell us that they are having problems, and other families will not tell us and will relax on the use of the brace. So in the clinic, we should always ask parents to bring the brace. So, and I want, even if you don't need to adjust the brace every clinic, if they bring the brace and we can kind of see how the wear of the brace, how the child reacts with the brace. Most of the children play with the brace, so they don't react in an odd way. So so we have to know if they are telling us, if we are doing teamwork, and if they are telling us the truth, or there's something hidden in there. So, but if they are having difficulties, and I always say this to parents, we are a team. So if you're having problems, we want to know, because if you're not bracing your child as according to the protocol, and I am seeing some subtle signs of relapses, my mind starts to think about other problems other than clubfoot, and I start thinking about neurological stuff and other things. And if you're telling me that you're being strict with bracing, then I'll be very worried and I might send you to other clinics. So if you're having problems, we'll work on it. And I see that most of the problems I see with nighttime bracing is between age a year and a half and 2 years, and then age 4 or 5. We recommend until age 4 or 5. So I'll tell them all kinds of strategies. I think the putting telling stories about the breast since the child is small, putting some protections in the brace with sponges or little toys that are done like for seat belts for children, and not having a bigger bed, you know, covering some cribs, have bars, and if the child puts the brace in the bars, then they are not comfortable. So I will advise them to have a bigger bed so that the child can move around, and I'll tell them that they have to be bossy. So if the child cries and they go and take off the brace, the child will understand that every time they cry, the father or mother will take off the brace. So it's like everything. If they don't want to eat soup, mom and dad has to show them that they have to eat soup and insist. And I think with the brace it's pretty much the same. So we'll work on strategies, but I think and I have some families that had some trouble, but I just want them to tell me I'm doing 6 hours or I'm doing 8 hours or I'm doing well. But I want to know the truth, and we'll work on that. I don't have families giving up on bracing, as far as I know.
Yeah. I think it's interesting that you're saying you went through all stages, starting with blaming parents, or you get stressed as a doctor when you see that it doesn't work, so you want to do something. I started to tell the parents, this is what you can do for your child. I realized that this, at least here in Sweden, works best because everybody wants to do the best for his child. So I started to use this sentence quite frequently, and actually it works quite well. Not always, but better than earlier, I would say. Any strategies in the US or in Dubai?
Well, a little relapse helps with compliance, right? So generally, my experience is that parents generally are quite compliant after the first relapse. So catching it early, putting 1 or 2 casts on it, and going like, see what happens if you don't wear the brace, is generally a very, very, maybe not the best way, but certainly helps in most cases, doesn't it?
Absolutely. Matt, I know you have a nurse practitioner who's helping you and addressing all the questions from the parents. Is this something you would definitely recommend to have if it's possible?
I mean, I think I definitely recommend accessibility. So if if they're having issues, they need to be able to reach you at your office and work through that quickly. And if they aren't able to do that and they lose faith in the process, that's where it becomes a problem. So communication is with many things is really key. If you're available and have a relationship going, it tends to be more successful.
And it's getting easier and easier with all these video accessibilities, right, and the future technique, if it works. Good. We have another question. What is the proper age to perform the anti-attendant transfer? Cristina, I think you mentioned that, but would you repeat it?
Proper age, I would say it's after age 3, possibly. Maybe at age 2.5, you already have a cert uniform, but I tend not to do after age 3 until age 5. Most of the children, if I see a relapse, I tend to cast and wait. And I usually would do it only after age 5 when racing stops and I know that they are really relapsing. And but you can do it after age 3 as soon as you have a cert uniform. But I don't know if there is an advantage unless you have a family that is not using the brace at all and the child is continuing to relapse. So you put 2 or 3 casts, tell them to go back to bracing. They don't do it. After 4, 6, 5 months, you see them again. They have a relapse again. Then it becomes very painful for the child to be all the time in casting, and then for this child, considering that they would be neurologically normal, I would do tibialis anterior transfer. So you can do it after age 2.5, 3, as soon as you have circumcision.
Mark, what is the youngest child you performed a tendon transfer on?
I think 2.5 as well. I would always take an X-ray to see if there's any ossification of the cuneiform, and then make my decision. I know that some have tried to put in the tendon into the cartilage, unlike of the bone. I have no experience with that, and wouldn't want to do that. I guess a follow-up question to that is the tibialis anterior transfer always the remedy? It seems to us, because we've learned that it's kind of almost a knee-jerk, right? 3 relapses and you say, okay, we're going to cast and put on the tibial, do the tendon transfer. I do have some feet where I feel like I don't know if I've really solved the cause for the relapses. Surely you change the dynamics of the foot, but sometimes I just feel it's not really what was wrong with the foot in the first place. Does anybody ever have that experience? Because there are some that actually relapse despite tendon transfer, and you kind of wonder why that is.
Yeah, I agree with you, Mark, completely. And that's and as we said, clubfoot is so heterogeneous. It's hard to have one answer for this. You know, my general age sort of thing is what Cristina was going to say. I really shoot for 4. You know, in most kids that I think need a transfer, I'll shoot till 4. And I think the risk of dropping the age, and this is when when I travel and talk about this, people always want to know how young can you go. And the main reason for that is to avoid bracing. You know, so I'm going to do a tendon transfer early as I can and stop bracing. That's the mentality I don't want out there. So are there some kids you do it at 2.5? There are reasons to do that in some patients, but that shouldn't be sort of asking how early can I go to get out of bracing? Because the problem with this is clubfoot wants to relapse, right? We know this. And the relapse rate goes down each year during the first 4 years. Relapses get less after that time. So if you do a tendon transfer at 2.5, you are still wanting to relapse. So you're still, as Mark said, you're gonna have to deal with this. You know, if you do a tendon transfer at 2.5 and you still relapse, you got to cast again, maybe do a soft tissue selective release, maybe do something different. So it's not a knee-jerk answer that this is, let's do it as early as we can. And will it work? Sometimes it will, because some kids actually don't need bracing for that long. This goes back to the etiology. So you're going to be successful, you know, sometimes because your relapse risk is going to be low in some kids, you know, after that. But it shouldn't be to try to get out of bracing, I guess, is the message, because you're still at risk for relapse.
Yeah,
and that's what kind of what Mark said. I mean, some of the tendon transfers, it's not the answer for the problem anyway. And that's so you're trying to do that. And I've seen that as well, Mark. The same thing. It's not always the problem.
Cristina, you wanted to make a comment as well?
I think that I absolutely agree with Matt, and I think that some kids who relapse after a tendon transfer, and I've seen maybe 2 cases, as I remember, of kids that I thought it was a perfect transfer, the perfect indication after age 5 or 6. I always think about neuromuscular something that might be there, but on the other hand, I see that it happens when they have a growth spurt. So it seems that their tendon Achilles, posterior muscles get tight, and suddenly you have a kid with tendon transfer who has a bit of equinus, and I've casted these kids, and they are both teenagers now, and I haven't done anything, but I've casted them like 2 or 3 times during these growth spurts, and I'm not sure how they will do in their late teenager years. So these are the odd cases that neurology doesn't find anything, and I'm not sure if the tendon transfer was the right answer. And that's one more reason why not to do it too early, because I think we might be missing something.
Before we move on, we take a final question from the audience. people want us to comment on bracing alternatives, talking about unilateral bracing and the ADM device. Any comments on this?
So,
Cristina?
So everything I've read about unilateral bracing does not seem to work as well as bilateral bracing. And so I do not recommend it to patients. I do have a lot of patients questioning about ADM. I'm not aware of any study that shows that ADM works in clubfoot. I know that some people will use it in the patient who does not want at all to use bilateral bracing and will tolerate an unilateral bracing, but I don't think that we can recommend it. Again, I don't think that there is evidence showing that it works. As far as I know, I haven't seen it described, but I might have not found it. Just
yeah. For my practice, I do use it exactly for that reason. In non-compliant patients, it's better than nothing, I would say. I think you can avoid progression. I don't think you can obtain any correction, in my view. I wouldn't disregard it completely. I think if you think of what you want to achieve with a foot abduction brace, those are movements that you theoretically and with good orthotics should be able to achieve with a unilateral brace. I just don't think we have found the right brace yet, but the subtalar abduction as well as the dorsiflexion in a more dynamic setting as we have in the traditional brace should theoretically be able to be constructed in a unilateral brace. If the ADM is the brace, I kind of doubt it, but I think at some point I do think there might be a unilateral brace that can be recommended. It is a bit surprising that after the ADM has been out there for what, for 5-6 years or more? Time flies, so I don't know, but it is a bit surprising that there's no early kind of papers that give early results. I mean, it would not be so difficult to do, but there seems to be nothing out there. I checked that a few months back. There's really nothing in terms of literature that supports it.
I actually used the ADM when it came out in the beginnings, only for cases with relapse, and in some cases it kept the correction, in some it didn't. In long term, it didn't at all. We checked this with gait analysis, and what concerned me the most was that it didn't keep the correction at all in smaller kids, which is the reason why I don't use it anymore. And regarding unilateral bracing, when I came here, this was the standard. And when I now follow all the kids who had this CAFO, we call it, the unilateral brace up on the knee, in some cases I see that they kept the correction, but almost all of them have a lack of plantar flexion, which I thought is interesting too. So the feet are definitely not that flexible. So, but I agree, it's better to use this than nothing. But I would always firsthand go with the Ponseti brace. Yeah, I think time is running, so we have to move on. Thank you for your comments. Now it's Mark Sinclair's turn. Thank you so much for being here as well. You're currently in Dubai since years. You're there, and you have a lot of experience with pediatric orthopedics and especially with clubfoot treatment. And we're looking forward to your talk.
Thank you, thank you. So thank you very much for having me, and I would like to thank the previous speakers for their excellent presentation. And I would like to point out that obviously this presentation also has Stephanie as a co-author. We've put a lot of work into this. It's a bit of a fringe topic, to be honest, but nevertheless quite interesting in terms of what can be done with relapses and how to evaluate them. So when the premise of this talk is that we don't have a good score to look at clubfoot and ambulatory children, and I think there's some literature to support this claim. If you look at literature pointed out here, how relapses are defined in one paper as any recurrent deformity that was classed as relapse, or recurrence defined as the need for any subsequent operative treatment. This obviously is not very differentiated. It doesn't really help when we look at clubfoot, especially in the walking child. To me personally, but also to the other authors of this paper, the problem was that the existing classifications don't really address what we see in the clinic when we examine a 2, 3, 4-year-old or older child. The DiMeglio classification bases its assessment very much on angles, doesn't have much of a dynamic component in its classification. And if you think of how we look at clubfoot when we examine a child in the walking ages, we look at a lot of dynamic factors. Is there an early heel rise? Is there a dynamic supination component during swing phase? Those things don't really flow into the DiMeglio classification. The Pirani classification, which I use frequently for all my initial clubfoot, also has criteria that I don't think lend very well to the walking child. If you think of the medial crease sign or the posterior crease sign, I don't really think that really helps in identifying a potential relapse in a clubfoot. The Ponseti-Lavec, just to have another one, also is partially X-ray based, and I do think that we've moved away from using X-rays to assess the quality of the correction of a clubfoot. So, and all of them don't have a functional component, as I had pointed out. This publication in 2013 I thought was quite interesting because they looked at 100+ feet and tried to classify a relapse pattern, which I think we all intuitively know, but it hasn't really been written down in a classification. So this paper suggests that there is different grades of classification, implying that obviously there's also a time factor that a relapse gets worse, and therefore a relapse is not a relapse, but it can be an early relapse with some signs, or it can be a late relapse with more severe signs. So I think what we see needs to be differentiated into what I call dynamic signs, for example, a lack of dorsiflexion or dynamic forefoot supination, versus a fixed deformity, which could be, as we all know, a fixed equinus or a fixed adduction, which translates to a loss in subtalar derotation or abduction. And of course, if you look at grade 3, it can be a combination of all of those things. But I think this is a fairly good classification, if you want, of different signs that we generally see. So this classification looks at dynamic versus fixed, or stiff versus fixed, but also ankle complex deformities such as the equinus versus more of a subtalar problem, which might be more of an abduction issue. So when we assess the clubfoot, what should a score have? And very much, if we remember the presentations by Shafiq Pirani, we need an easy score. It needs to be easy to use, and I think that Pirani is probably one of the scores that really follows this rule very well. It has to be reproducible, it has to be valid, obviously, and it should detect early signs of relapse. And it goes back to, again, what is a passive or structural sign of a relapse, for instance, a reduction of range of motion, and what is an early dynamic sign, for example, dynamic forefoot supination or early heel rise. To identify this, we had the opportunity to go to Uganda to an established clubfoot project, and we looked at 100 children that were treated in these projects. and looked at different kind of signs. So we kind of had 19 signs that we looked at, starting looking at the child from a standing position, walking, seated, and also functions like squatting. The result really was that many of these signs really don't help. If you look at squats, for example, that many children cannot perform this. And in addition, we had lots of signs that just had a ceiling or flooring effect that showed really no differentiation between a good and a bad outcome. So after this first attempt in identifying what signs could be helpful in assessing a possible relapse, we came up with 7 remaining signs essentially, which was 3 that addressed the ankle or the hind foot, if you want, which included passive ankle dorsiflexion. So how much can the examiner dorsiflex the ankle? And then an active dorsiflexion. So how much can the patient on command bring the foot up, and how much beyond neutral can he bring his foot? The other was the early heel rise during gait, because obviously that would also relate to a lack of dorsiflexion in the ankle joint. 4 other signs would address that more the subtalar kind of a part of the foot. So we would look at the hind foot. We would look at if there's any forefoot or fixed forefoot supination when we look at the foot, dynamic forefoot supination during swing phase, and what we call passive subtalar abduction. Everybody who knows the Pirani classification, we kind of borrowed that test of subtalar mobility from the Pirani classification itself. So when we classified these, we said, how do we look at them? And we have a standing, walking, sitting sequence, to be honest, and that works very nicely for a clinical setting. So we look at the child standing, we look at the child from the back, and we have a look at the varus at the heel alignment, and if there's a varus or a valgus. We will also look at the child from the front and see if there's a fixed forefoot supination. So essentially, if the head of the first metatarsal touches the ground or not. We have the child walk, and we'll see if there's any dynamic forefoot supination, and we will also look at the child from the side to see if there's an early heel rise. As a last phase to this proposed test, we examine the child in a sitting position, and we would see what the passive subtalar abduction is. So essentially, the test that we know from the Pirani classification. We would look at active ankle dorsiflexion and at passive ankle dorsiflexion. So what we found, I'll go back one second. What we found when we did this, we did a second round of testing with about 30 children actually here in Dubai. And with those 7 signs, we had 3 examiners looking at the children. Now the inter-observer reliability here was not good. And what we identified is that we all look at those signs slightly differently, which was kind of interesting. So we went about to standardize each sign in order to improve that inter-observer reliability. So when we look at the child in hind foot varus, we decided that we would draw a perpendicular line from the insertion of the Achilles tendon and see where the center of the heel was. If the center of the heel was medial to that line, we would call it a varus. If it was on or lateral to that line, we would call it a valgus. Here you have an example, maybe an exaggerated and easy example, but you can see here on the left, valgus hindfoot, and on the right, a definite varus hindfoot. So we give 2 points for a positive varus and 1 point for a valgus or neutral hindfoot. The next test would be looking at the child from the front when the child is standing and see if there is fixed forefoot supination, which means that essentially the head of the first metatarsal doesn't connect with the ground, doesn't touch the ground. And if that is the case, then we have a positive sign. If there's a normal position of the metatarsal, then it's negative and gives 1 point. And you can see here an example. By the way, here, we talked about tibialis anterior and recurrence. There is one of them. And you can see on the left side here that the child's right foot, there is clearly a fixed forefoot supination, whereas on the left foot, this is not the case. We would then move on to a walking child and have a look at the child. You can see in the slow motion, the slight dynamic supination or walking supination, and that is actually not that easy to see. And you will see with the validity test, with the inter-observer reliability test, that those dynamic signs within the PBS are the ones with perhaps the least agreement between the examiners. You can see here the images of the child on the far left. You can see a dynamic supination, and on the right of the child, you can see a normal swing through of the foot without elevation of the first ray. So this would be how we define walking or flexible forefoot supination. The second sign in the walking child would be looking at the child from the side. And as you know, when the tibia is perpendicular to the ground, we would want to have good heel contact. Clearly, if this is not the case as on the left, then we would consider this an early heel rise. Likewise, we would then bring the child to a sitting position, and we would measure ankle dorsiflexion. Now, that is often more difficult than said. We need to make sure that the heel has contact with a board or with a book, because otherwise we do get a little bit of mid-foot break in some children, which would mimic better dorsiflexion than there actually is. So a great attention to detail here seems necessary. Depending on how much dorsiflexion there is, we give points from 4 to 1 and rate the ankle range of motion accordingly. Important is also the active dorsiflexion in our view, and it certainly differentiates a good functional foot from a not so functional foot. If the child can dorsiflex beyond neutral or into the green area, then generally the foot function is a lot better. The next sign in the sitting position is the subtalar motion. You all know this from the Pirani classification. I've mentioned it before. If obviously you cannot abduct beyond the neutral position of the foot, you have a problem. You have a lack of movement in the subtalar joint. If you can go beyond the neutral position, neutral being defined as the long axis of the tibia in line with the long axis of the first metatarsal, then the more abduction you get, the better your rating will be. So this all will give us what we call the PBS score. It's 7 signs. According to the numbers you can allocate to each sign, you can have a 7 to 18 PBS score. So what is the inter-observer reliability? As I said before, we worked on this. Initially, it was not good. With the definitions that we kind of made for each sign, we then had a third round of testings in Stockholm with a patient population that Stephanie offered for this particular paper. And we looked at the inter-observer reliability, which significantly improved, as I will show you in the next slides. We also tried to find a certain measure for validity of the test, and the Roy score seemed like a good start for us. The Roy score, as you all know, or the modified Roy score is a parental satisfaction questionnaire that essentially ranges the outcome from good to bad. It's 9 items, and it's fairly simple and easy to use, but it gives us a good idea of how the parents see the function of the foot, which ultimately is probably quite important. Now, when we look at the Spearman rank correlation, we can see that actually a good PBS score correlates with a good Roy score and measured 0.73, so it's considered moderate to good. So this was the test for our validity. In terms of the inter-observer agreement, we looked at how each examiner agreed with the other. We came up with a total PBS score of 0.93, which if you compare the kappa value with other assessments of other tests done in the past is actually quite good. As you know, with these values, an almost perfect agreement would be anything above 0.81, and that applies, to be fair, also to the DiMeglio-Pirani classification. Another test which has been looked at is the International Clubfoot Study Group evaluation, which had slightly lower scoring. So I'd like to take you through an example here before we close. You can see this patient here, and you can see how easy the scoring would be with a PBS and how it actually really helps in understanding where the problem in each particular relapse would be. So here, again, the example on the left picture, attachment of the Achilles tendon, perpendicular line. The center of the heel is to the lateral side of the line. So you would say the varus is absent. You would also say the forefoot supination or the fixed forefoot supination is absent, as the metatarsals connect very nicely with the underlying surface and there is no elevation of the first ray. Dynamic forefoot supination, you would see in the next slide. This one shows the early heel rise. You can see where the tibia is perpendicular to the ground, we have good heel contact. So again, here an early heel rise as a dynamic sign is not present. In terms of dynamic forefoot supination, you can see that this is not an easy sign to read, especially in a clinic setting. But I kind of captured this picture of the video, and you can see here, also here, no significant elevation during the swing through phase. We continue then in a sitting position. As mentioned, we look at active dorsiflexion. This is not a great photograph from my clinic, but this child did not have dorsiflexion beyond neutral. Also, the dorsiflexion here, the passive dorsiflexion with a book as or a wooden board, you can see that there is not that much between 5 and 10 degrees, and ultimately also the passive subtalar abduction was slightly limited in this patient. So this would provide us with a score of 11. As a final thought, I think it is important to understand, at least it is to my practice, that a recurrence is not static. A recurrence starts slowly, and if you look at those signs that we have incorporated in the PBS score, they all very often, if you look at the timeline at the bottom, they often come at different times. So with a PBS score, I do feel we can kind of not only identify a relapse, but I think we also kind of understand the timeline, if this has happened recently or if this is something that has been there for a while. So we have signs that would be considered more early signs, such as a decrease of subtalar abduction, a gradual reduction of range of motion of the ankle, or a dynamic supination during swing phase. And we also have signs that really talk more about significant relapses, such as a hindfoot or heel varus, no active dorsiflexion, a positive heel rise sign, and a fixed forefoot supination. And the idea really would be, at the end of the day, to have to see if the PBS can actually predict what is required in terms of treatment, because this is what we need. We need a score that tells us if the foot is good or bad, but also what is most likely the treatment of choice. If you have an early one, you might recast. So what PBS recommends recasting versus tenotomy versus tenotransfers, or even versus a more significant surgery, I think more needs to be looked into that particular aspect of the score, which would then really make it extremely helpful for the common practice. One of the first steps is obviously that we have the PBS as a measure for the Swedish National Clubfoot Registry, which I think will give at some point a really good database to perhaps look into exactly that, what scores were given what treatment, and I do think that there will be a correlation, but that is yet to be demonstrated. So in conclusion, for this summary of this particular classification, I would say that PBS is a fairly easy tool to use. Exactness in each test segment is important, but you get actually quite good inter-observer reliability. It is also valid when you compare it to the Roy score. Obviously, validity would need to be tested more. For instance, with foot pressure patterns might be one of the suggestions that we're looking into at the moment. With this, I would like to thank you for your attention.
Thank you so much, Mark, for this very good presentation. I think there are a couple of questions upcoming. It gives me actually a hard time to see them. I'm wondering, Sunny, can you help us to put up some questions, or can you read them for us? Because I can't see them over here. I just can see that there are some questions. I don't hear anything from Sunny.
She's using the chat, asking to wait a little bit.
Yes.
So I mean, the question, I think, when we deal with clubfoot, especially also in the when we talk about what is a good result, this is something that has always bothered me a little bit, because obviously what is a good result has changed over time. If you ask the pre-Ponseti people what is a good result, I think many feet that we consider functional and quite good are not good results to these people, right? They want dorsiflexion of 30 degrees in the ankle joint, and we know that that is not necessary. And I wonder what the criteria are. Is it do we all have the same criteria? I mean, as an example, in the Middle East, I think where squatting, or in Asia, where squatting is quite an important part of daily life, maybe, as you know, Dietz in his paper says a 7-degree ankle dorsiflexion is really not that good. Whereas in cultures where you spend more time on a chair, I agree. It's a bit like the knee replacement argument in Europe. I remember when I was a resident, 90 degrees of knee flexion after total knee replacement is good. But in the Middle East, everybody's talking about the maximum knee flexion knee replacement, because obviously it is more important in day-to-day life to flex more than 90 degrees. So I'm not sure if that is, if we're quite there yet, where we say this is a good result and that is not. And the same goes for relapses. I mean, what is a relapse? Does Cristina treat a slight dynamic supination during swing phase, or do we wait and observe? All these questions are kind of interesting, because I think we all have very different approaches also to relapses.
Yeah.
Absolutely, I agree. It's a cultural question as well, and it's a question of definition. What is good or bad? There is actually a question to you, Mark. Do you use the score in your daily clinic?
I do. I think at the beginning it was very difficult for me to do, because obviously when you introduce a score, it kind of changes your whole routine with the patient. But I think those seven signs, if you want, we all look at them, maybe subconsciously, right? But none of those 7 signs that I described go unnoticed when we look at the child. We just don't actually write it down in this specific pattern. I think it's a shame, because we could be a lot more precise if we did.
Absolutely. What might be the next step with the score?
well, first of all, we have to use it, right? Well, first of all, we have to use it. But obviously, the idea, I tried to mention that at the end. I really think that this score has because it looks at early signs and late signs, I think we can perhaps create a kind of a guideline as to how to treat them. If we know that a PBS score of 15 shows initial reduction of movement in the subtalar joint, slight dynamic supination, we put casts on, then that is what we do. If we know that if you have a hindfoot varus, you have to put a whole series of casts and probably a tendon transfer, then that that can guide our therapy. I think that might be quite helpful. But this is something that needs to be looked at. At the moment, it's really just a tool, I think, with the patients that we follow in the clinic every couple of months, the ones that we worry about, when we say, look, this is a foot that is getting worse, but you can't put your finger on it. You say, well, it's a little tighter than last time. We all have these patients, and we don't really quantify it that well. So I think there is a lack of a good score for these children. I think PBS might be the one to fill that gap. I don't know.
Mm-hmm. There's actually somebody who's wondering how we measure the abduction against the fixed talus. It gives people a hard time to measure this. Any tips and tricks from your side?
Well, I mean, the ones that use the Pirani classification would know how we do this, right? Essentially, it is the Ponseti maneuver kind of that we do when we put our thumb lateral to the neck of the talus, and we take the foot and essentially rotate the foot calcaneus complex, if you want, around the talus and see how flexible that is. And I do agree that one of the challenges of this score is that you have to somehow quantify it, a bit like the DiMaglio method. I mean, what is 5 degrees and what is 7 degrees in movement? And so I think the less categorizations you make, the easier it is. Ultimately, in this one, it's really bad if you can abduct beyond neutral, and then you have a bit of abduction, a lot, and something in between. It is very difficult to give it actual numbers. I agree.
Mm-hmm. Cristina, do you have access to gait analysis in your clinic? And is it the physiotherapist who measures? Is it you who measures, or?
For classifying, we measure. So for the regular orthopedic clinic, we don't have a physiotherapist with us. The only place we have a physiotherapist with us is in the neuromuscular clinic, where we see Duchenne patients and other kinds of patients, not the regular clinic. So I usually measure this, and I eyeball it unless it's for research purposes. I will use a goniometer, but for my regular clinic day, I just see like about 10 degrees, 15 degrees of dorsiflexion, and I admit I don't measure every clubfoot baby. Kind of, I used to do it when I was in beginning my practice and Ponseti method, really obsessive. I even photographed the cast to measure abduction in the cast, but now I usually just eyeball it. Unless it's a relapse and I'm taking the child to the OR and I want a strict measurement, but I usually just eyeball it.
There's another question addressing relapse and what we do, and if the anterior tendon transfer is the solution for everything. Probably not. People are wondering, is there any room for more extensive surgery? Mark, what do you think?
I try to avoid surgery. I've had one horrible experience many years back where I tried to do a tiband transfer, and the patient ended up not having a tiband. so the answer that this has happened to me once, which was not very pleasant. So the answer is no. I don't think tibialis anterior is the silver bullet. And I think for every transfer, I think you have to consider if you have to kind of. I try to imagine what the problem of the foot is. Very often you have a bit of a rigid subtalar joint, and yes, you can get it better, but there's still something that kind of doesn't give you that full movement. And I think that even those sometimes don't do perfectly after tiband transfers, and you maintain especially you see it in the heel, that it doesn't really go as much into valgus as you would like to see it after the tiband transfer. And I don't know what the answer is. I mean, the other question is, do we ever look at potential cartilage coalition or fibrous coalition between? We don't really consider that ever in our assessments of relapses, but that I guess is a reasonable question in those difficult clubfoot relapses. So no, I don't think the tiband is the solution for everything.
For everything. Matt, do you think there's any room for Cincinnati approach or every other excessive surgery in some cases? For example, alpha-glycotic clubfoot?
Yes. So the answer is all feet are different. And yes, more intervention is needed in some feet. And I say that carefully, as you know, as that's not, the message that, I want to portray is that club feet need surgery. And, by far the vast majority of isolated club feet don't need anything done. And I think as Mark alluded to, some of the things we have to watch is, what is the measurement of a good outcome? What are we trying to achieve? And I think some of the reasons for failure that I see in tiband transfers as being the magic bullet is, number one, lack of preoperative appropriate serial casting. So some people indicate TA transfers and just go do it. And if you do a TA transfer on an uncorrected foot, it doesn't work. That's not going to be effective. There are some kids that, as Mark said, they're more limited and their hindfoot varus may not fully correct. They get to neutral and they don't go beyond, and those are at higher risk. And I think often you look at the talonavicular joint. So if your serial casting still doesn't reduce the talonavicular joint, you're going to pull back around. You know, so could there be an indication there at the time of your TA transfer, if your casting has not fully reduced the talonavicular, you know, an isolated talonavicular release, they'll have the foot swing over. A la carte can be appropriate, but there's never an indication in my mind for a extensive, you know, soft tissue release is the answer for clubfoot. And that again is expectations and outcomes. You can improve immediately on the table of motion, you know, with doing that, but as we all know, you lose that over time. You know, so you know what is good enough is what you have to ask yourself. What degree of dorsiflexion is good enough? And with the TA transfer, you know, paying attention to the hindfoot. If you do a TA transfer and you're still on Aquinas and you don't address the heel cord, if it needs to be addressed, it's not going to be effective either. You have to address what's there in terms of deformities. So it's more than, it's not a cookbook sort of answer.
Cristina, any comments about the physiothesis, the distal tibia, ventral tibia?
So I've never done it myself. I've seen a recent paper talking about it in surgically treated feet, that it might work. I think, but I've seen also papers claiming the other way around. So I'm not sure if it works. I probably would consider it in the child who had surgically treated feet, which we now just see teenagers for the most, and has equinus and still has an open growth plate. I probably would consider it, but I think we really don't know in which children will it work. It really depends on the rate of growth of the distal tibia, and in some children with club feet and with those surgically treated feet, we see that the distal tibia growth plate sometimes is not that close to normal. So I doubt how it can work, but I would consider in those feet, probably not in the Ponseti treated club feet.
Mark, is this a method you use?
I've used it, but as equally, so in some syndromic kids, I've used it, and it takes a long time. I don't think there's a lot of growth in the distal tibia, so I think it's a long-term thing. And I think some of the papers, what they criticized or what they observed is that there's quite a bit of a rebound effect after removal of the 8 plate or whatever you use. So I'm not sure if that's a good method. I think some skeletal dysplasias where you see that the joint is in a bad situation anyway, I think it's reasonable to do. But I think anterior epiphysiodesis is better around the knee. We have good results in the distal femur. It's a faster growing physis. I just think the distal tibia is a slow growing physis, and it's sometimes not really worth the issue. I think with orthotics you can always resolve a 5-degree Aquinas, because you wouldn't do this anyway in an Aquinas that is 10, 15, 20 degrees. I don't think you'd be successful. So if you have a 5-degree Aquinas, I would rather go for some kind of shoe modifications in those children than bother them with an anterior hemiepiphysiodesis.
Matt, any comments on that?
Oh, I completely agree with everything that's been said. I mean, I've used it. It's very selective, and the cases I've typically used it in are the kids that have had repetitive soft tissue releases that are just socked down into Aquinas, and it's usually in my hands then combined with a distal tibial osteotomy, you know, trying to get to neutral and then maintain it. You know, because if you do your distal tibial osteotomy and then they're growing, they're going to grow right back, you know, to where they were. So the epiphysiodesis can then kind of maintain you in a plantar position. But you know, whatever you gain with a osteotomy or epiphysiodesis, you lose in the other plane. You're really just trying to maintain neutrality, you know, is what you're trying to do. And so there's, it's only in the very difficult kids that I would entertain it.
Thank you very much. I think we have to finalize our webinar at this point. I would like to thank the audience for your interest, for listening to us. I would like to thank you, the speakers, for your help and for your great presentations. It was a pleasure and honor to have you, and looking forward to do further projects with you. And I would really like to thank also EPOS and Orthopediatrics for putting up this webinar, and stay safe and in this pandemic, and keep healthy. Thank you so much. Have a nice evening or a nice day, depends on where you are in the world. Bye-bye.
Bye-bye.
Everyone. Thank you.
Thank you.